Welcome everyone. Today we'll review a practical, evidence-based approach to caring for children with Down syndrome, based primarily on the latest American Academy of Pediatrics Health Supervision guidelines. Rather than focusing only on the diagnosis itself, we'll discuss the lifelong medical surveillance these children require, from the newborn period through childhood. The goal is early recognition of associated conditions, timely intervention, and family-centered care that optimizes health and developmental outcomes. Why this matters. Down syndrome remains the most common chromosomal disorder compatible with long-term survival, occurring in approximately 1 in every 700 live births. Fortunately, advances in pediatric cardiology, neonatal care, and multidisciplinary follow-up have transformed the prognosis. Today, life expectancy commonly exceeds 60 years. As pediatricians, our responsibility extends far beyond confirming the diagnosis. We coordinate comprehensive surveillance involving the cardiovascular, endocrine, gastrointestinal, neurodevelopmentally, sensory, and hematologic systems. Early diagnosis is the key that opens the door to appropriate screening and timely referral. Genetics and etiology. There are 3 genetic mechanisms responsible for Down syndrome. Approximately 95% result from meiotic nondisjunction, producing complete trisomy 21. The risk increases with advancing maternal age. Robertsonian translocation accounts for roughly 3 to 4% of cases. This form is especially important because nearly 1/3 may be inherited. Therefore, parental karyotyping and genetic counseling are essential for recurrence risk assessment. Mosaic Down syndrome is less common, representing 1 to 2% of patients. Because only a proportion of cells carry trisomy 21, the phenotype can be highly variable and sometimes milder. Understanding the genetic mechanism directly influences family counseling, prenatal screening, and diagnostic confirmation. It is important to distinguish screening from diagnosis. Screening methods, including cell-free DNA testing, nuchal translucency, and maternal serum markers, estimate the probability of Down syndrome but cannot establish the diagnosis. Definitive prenatal diagnosis requires chorionic villus sampling or amniocentesis for fetal karyotyping. After birth, any infant with clinical features suggestive of Down syndrome should undergo peripheral blood karyotyping, regardless of prenatal screening results. Rapid FISH testing provides preliminary information within 1 to 2 days, while the complete karyotype confirms the chromosomal mechanism and recurrence risk. Clinical features. No single physical feature confirms the diagnosis. Instead, recognition depends on the constellation of findings. Common characteristics include hypertonia, a flat facial profile, upslanting palpebral fissures, epicanthal folds, brachycephaly, small ears, a flat nasal bridge, a single transverse palmar crease, and the classic sandal gap between the first and second toes. Brushfield spots may also be present. Ultimately, the diagnosis must always be confirmed genetically. Delivering the diagnosis. Perhaps one of the most important responsibilities we have is how we communicate the diagnosis. Whenever possible, both parents should be present in a quiet, private environment. Begin by congratulating the family on the birth of their baby before discussing the diagnosis. Use respectful, balanced language and avoid outdated terminology. Families need accurate medical information, but equally important, they need hope. Explain that children with Down syndrome today can enjoy meaningful lives with appropriate medical care, educational support, and early intervention. Before discharge, provide written resources, arrange genetics referral, and initiate early intervention services. The newborn checklist. The newborn period is the ideal time to establish baseline evaluations. Every infant should receive an echocardiogram within the first month of life because congenital heart disease occurs in nearly half of affected infants, even when the physical examination appears normal. Hearing screening should be completed before discharge, with ophthalmologic evaluation arranged during infancy. Thyroid function should be assessed at birth and monitored regularly because hyperthyroidism is common and frequently asymptomatic. A complete blood count is recommended to screen for transient abnormal myelopoiesis, polycythemia, and other hematologic abnormalities. Finally, evaluate for gastrointestinal obstruction, hip instability, and initiate referrals for genetics counseling and early developmental intervention. Cardiac evaluation. Congenital heart disease remains one of the most clinically significant comorbidities in Down syndrome. Approximately 50% of infants have structural cardiac defects. The most common lesion is the atrioventricular septal defect, followed by ventricular septal defects, atrial septal defects, and patent ductus arteriosus. Tetralogy of Fallot occurs less frequently but should always be considered. Pulmonary hypertension is another important concern due to the combination of congenital heart disease and airway abnormalities. For this reason, echocardiography is recommended for every newborn with Down syndrome, regardless of auscultatory findings. Down syndrome care is not a single consultation. It is a lifelong partnership between families and a multidisciplinary healthcare team. Evidence-based surveillance allows us to detect complications before symptoms develop. Early intervention improves developmental outcomes. Timely cardiac, endocrine, sensory, and hematologic screening reduces preventable morbidity. Gastrointestinal and endocrine surveillance. Let's now turn our attention to gastrointestinal and endocrine health, two areas that require lifelong surveillance in children with Down syndrome. Beginning with the gastrointestinal system, duodenal atresia is one of the classic congenital anomalies associated with trisomy 21. Clinically, these newborns present with early bilious vomiting and abdominal radiographs demonstrate the characteristic double bubble sign. Prompt surgical referral is essential. Hirschsprung disease is also significantly more common, with a risk approximately 2 to 15 times that of the general population. Any infant with delayed passage of meconium, persistent abdominal distension, or chronic constipation should be evaluated promptly. As children grow older, we must remain vigilant for celiac disease. Many patients present atypically with poor growth, iron deficiency, chronic constipation, or even subtle behavioral changes rather than classical diarrhea. Current AAP recommendations advise screening symptomatic children and maintaining a low threshold for testing using tissue transglutaminase IgA along with total serum IgA. Moving to endocrine surveillance, thyroid disease is among the most frequent medical problems in Down syndrome. Congenital hyperthyroidism is more common, and autoimmune thyroiditis becomes increasingly prevalent with age. Because clinical symptoms are often subtle or masked by the underlying condition, routine laboratory surveillance is essential. Thyroid function should be assessed at birth, repeated at 6 months and 12 months, and then annually throughout life. Finally, obesity deserves proactive attention. Reduced resting energy expenditure, hypertonia, and endocrine abnormalities predispose these children to excessive weight gain. Growth should always be monitored using Down syndrome-specific growth charts, with early counseling regarding nutrition and physical activity. Hematologic and oncologic considerations. Down syndrome has a unique hematologic profile that every pediatrician should recognize. During the newborn period, polycythemia and macrocytosis are relatively common. Therefore, obtaining a baseline complete blood count with differential shortly after birth is recommended. One particularly important neonatal condition is transient abnormal myelopoiesis, or TAM. This occurs in approximately 10% of newborns with Down syndrome and is characterized by circulating blast cells resulting from acquired GATA1 mutations. Although TAM resolves spontaneously in most infants within the first 3 months of life, it should never be dismissed as completely benign. Approximately 20% of affected infants later develop myeloid leukemia of Down syndrome, particularly acute megakaryoblast leukemia. These infants require close hematology follow-up and serial blood count monitoring during early childhood. Beyond infancy, children with Down syndrome remain at substantially increased risk of leukemia. The risk of acute myeloid leukemia is increased by approximately 10 to 20-fold, while acute lymphoblastic leukemia occurs roughly 20 times more frequently than in the general pediatric population. Fortunately, despite the increased incidence, treatment outcomes, particularly for all, are generally favorable when recognized early. The key message is simple: unexplained pallor, bruising, prolonged fever, hepatosplenomegaly, or persistent cytopenias should never be attributed solely to Down syndrome. Hearing, vision, and airway. Sensory surveillance plays a critical role in maximizing developmental potential. Hearing impairment is extremely common, largely due to recurrent otitis media, eustachian tube dysfunction, and anatomically narrow ear canals. Every infant should complete newborn hearing screening, followed by formal audiologic assessment by 6 months of age. Thereafter, hearing should be reassessed every 6 to 12 months during early childhood, as conductive hearing loss may develop gradually. Vision screening is equally important. Children with Down syndrome have increased rates of cataracts, refractive errors, strabismus, and nystagmus. An ophthalmologic examination should be performed by 6 months of age and repeated annually thereafter. One reassuring point worth mentioning to families is that brushfield spots, although characteristic, do not impair vision. Finally, airway management deserves particular attention. Hypertonia, macroglossia, midface hyperplasia, and adenotonsillar hypertrophy all contribute to a remarkably high prevalence of obstructive sleep apnea. Importantly, many affected children are asymptomatic during the day despite significant nocturnal disease. For this reason, polysomnography is recommended by 4 years of age, even in children without obvious symptoms. Neurodevelopment and orthopedics. Developmental care begins at the time of diagnosis. Most children with Down syndrome have mild to moderate intellectual disability, with relative strengths in visual learning and social interaction, while expressive language often remains the greatest challenge. Referral to early intervention services should occur immediately after diagnosis. Physical therapy, occupational therapy, and speech therapy significantly improve long-term functional outcomes and should never be delayed while waiting for developmental concerns to emerge. As children grow, regular screening for autism spectrum disorder, ADHD, anxiety, and depression should be incorporated into routine health supervision. Orthopedic surveillance is equally important. Generalized ligamentous laxity contributes to hip instability, patellar instability, scoliosis, and gait abnormalities. Atlantoaxial instability deserves special attention. Although radiographic instability occurs in approximately 10 to 20% of patients, the majority remain asymptomatic. Current AAP recommendations no longer support routine cervical spine radiographs in asymptomatic children. Instead, clinicians should perform careful neurologic examinations and evaluate for symptoms such as neck pain, gait changes, weakness, hyperflexia, or bowel and bladder dysfunction, particularly before participation in competitive sports or activities involving excessive neck flexion or extension. Finally, dental health should not be overlooked. Delayed tooth eruption, small teeth, malocclusion, and periodontal disease are common. Dental care should begin by 1 year of age, accompanied by regular preventive oral hygiene counseling. Lifelong health surveillance. Summary. As we conclude, this timeline summarizes the lifelong medical surveillance recommended for individuals with Down syndrome. During the first month of life, priorities include confirming the diagnosis with karyotyping, obtaining an echocardiogram, baseline complete blood count, newborn hearing screening, thyroid evaluation, and initiating genetics consultation and early intervention services. By 6 months, audiology, ophthalmology, and repeat thyroid testing should be completed. During early childhood, surveillance expands to include celiac disease screening when indicated, sleep study by 4 years of age, and continued monitoring for leukemia, developmental progress, hearing, vision, and thyroid disease. Beyond 5 years, annual health supervision continues throughout life, incorporating behavioral assessments, ongoing endocrine and sensory surveillance, cervical spine assessment when clinically indicated, and planning for the transition into adolescent and adult healthcare services. Ultimately, caring for children with Down syndrome is not about treating a chromosome. It is about recognizing predictable health risks, preventing complications through evidence-based surveillance, and partnering with families to help every child reach their fullest potential. Thank you for your attention.